Good afternoon. It's really a pleasure to be here today. So I'm not Sanjeev Arora, and he sends his regards and is sorry he wasn't able to be here and speak in person. But I have been very interested in the work that Project ECHO's been doing in New Mexico. The project was created about 10 years ago to address a specific problem, which was that in New Mexico, there are about 30,000 people that have hepatitis C. And when Dr. Arora moved there from Boston about 12 years ago, there were about 5 liver doctors in the state facing this issue of trying to figure out how to treat 30,000 people or assess them for treatment. And in thinking about that, he came up with an innovative idea. A solution, or his solution was, let's see if we can train primary care doctors scattered throughout the state to become local experts in assessing and treating viral hepatitis. And we at the university will act as mentors of these doctors and co-managers of these patients. And maybe if we do that, we might be able to make a dent in addressing this problem. So there we go. So I'm Bruce Struminger, and I'm actually with the Indian Health Service. And as was mentioned, I'm going to tell a little bit of a story about how I got to be here and why I'm here with the Indian Health Service talking about Project ECHO, but also talk about a little bit about my training as a physician and what drew me to the Indian Health Service and to some of the other work I've done and how that actually relates to this initiative. So I did my training in internal medicine as a resident at the University of Michigan in Ann Arbor, and my wife and I decided we wanted to move to the Southwest for a bunch of different reasons. My wife's a herpetologist and really interested in lizards and snakes and loves the desert. And I was really interested in Native Americans and taking care of them and working for the Indian Health Service. And when I went out to interview at 5 or 6 different hospitals in Arizona and New Mexico, one of the things that really drew me to the facility I ended up working at in Shiprock, New Mexico, was the fact that they had a program, a collaboration with Columbia Medical School, and they had 2 medical students rotating through there every month learning about primary care internal medicine. And here I was, after years of being at universities and in academic centers, to go from a very vibrant intellectual community out to a very remote area. One of the things that I was worried about was being kind of isolated in a lot of ways. So the idea of being able to be in a kind of more stimulating academic, semi-academic environment with these medical students keeping us on our toes, anyway, was an incentive for me to choose this one hospital of over 3 others that had very similar patient populations. From there, though, after 5 years of working there, I ended up transferring to the Centers for Disease Control because I was very interested in global public health work. And for the last 3 years, from 2009 to 2012, I was the country director in Vietnam. One of the main issues we were trying to help the Vietnamese government address was HIV, and that was the source of about 90% of our funding from the US government was to help address the HIV epidemic there. That epidemic is driven by injecting drug use. And similar to HIV, hepatitis C is primarily transmitted through injecting drug use around the world. And what we found in Vietnam was that 50 to 70% of the HIV-infected people there were also co-infected with hepatitis C. So this was a huge public health issue. It was one, frankly, we were doing zero about. Our funding was for HIV. That's what we were focusing on. Certainly through the harm reduction efforts that we were helping with in our prevention efforts, the same things that prevent HIV would prevent hepatitis C. So on one level, we were kind of by association helping prevent Hep C, but we were doing nothing to actually actively test and treat it. So then about a year ago, or actually while I was there, I was thinking a lot more about hepatitis C and rather frustrated that we really had no resources to address that big problem for them. It's also true in Vietnam. The number 2 cause of mortality for men is liver cancer, and one of the main causes of liver cancer in the United States and around the world is viral hepatitis. And while I was there, though, I ended up reading this really interesting article in the New England Journal of Medicine in June 2011, and that article was by Dr. Aurora about this program they started in 2002 to train primary care doctors to treat patients with viral hepatitis. And I was super interested and compelled by that article and knew that when I was moving back to the US to do some more clinical medicine and mix that with public health, that I was going to be working back on the Navajo reservation in a actually slightly more remote place than I worked before, about an hour west of Shiprock, New Mexico. So I was going to have even more need of access to specialists. My colleagues, I have about 6 or 7 other primary care docs who are family practitioners, 1 other general internist, but the closest specialists are about 4 hours away at the University of New Mexico. So knowing that there might be, I could have access to some expert colleagues through a program like this, anyway, was very interesting, and I started participating in it. So now I'm just going to mention a couple things about where I'm at. This is a slide of the Navajo Indian Reservation. It's about the size of West Virginia. I think most people probably realize it's in the Four Corners region. That upper left corner is the southern part, southeast part of Utah, southwest Colorado, and then northeast Arizona. The biggest part of the reservation is in northeast Arizona, and then this piece on the right is in New Mexico. And that's I-40 kind of going along the bottom there. I work kind of right up 20 miles west of the Four Corners. So pretty remote. This is a view of our health center, which was opened about 6 years ago. It serves a population of about 7,500 patients in a very beautiful area. It's in Red Mesa, Arizona. That is Red Mesa down there. As you can see, this is a typical traditional Navajo hogan, which is what most Navajo lived in up until about 30 or 40 years ago. Most of them now live in houses like that. Some still live in both. And this is the view from right next to the health center, which is pretty representative of the population density of that area. So very low population density, lots of space. The roads are not very good. So, and luckily we've been getting a lot of rain recently. Colorado's gotten more than we've gotten, but we've gotten a lot in northern Arizona and New Mexico. And these roads turn to mud, become very difficult to traverse, which makes it difficult for the patients to get into our clinic, much less make a drive to Flagstaff or Albuquerque. So now on to Project ECHO. So the mission of Project ECHO is to expand the workforce capacity to provide best practice care for common and complex diseases in rural and underserved areas and to monitor outcomes. So though the project started with hepatitis C 10 years ago, it's expanded to include initiatives related to HIV, to rheumatoid diseases, rheumatologic diseases, chronic pain, as well as an initiative now funded by the Centers for Medicaid and Medicare to address patients with multiple complex medical problems like a combination of diabetes and coronary artery disease and congestive heart failure, et cetera. In terms of the model, the basics are that they use telehealth technology, primarily video conferencing, multipoint video conferencing, to connect these primary care providers, doctors, mid-levels, not only in rural areas, but also in urban clinics who might be in an underserved part of the town that don't have easy access to the university, to share best practices, so the academic clinicians keeping those doctors up to date. And a main effort of this is to reduce the variability in the care that's being given across the state, to basically, disseminate a standard of care and some algorithms that guide the doctors in their treatment of these diseases, and try and narrow the variability in how one doctor in one part of the state is treating versus a doctor in another part of the state. In doing that, to improve the quality and the outcomes of the care they're giving. And the method is these doctors present real cases, and they do it in a formatted way so that they fill out a 1 to 3 page form that basically gives the subject matter experts at the university all the information they need and not a lot of additional information, so that when they're presenting their patient, they can do it in 5 to 10 minutes. And in a typical 1 hour video clinic, somewhere between 6 and 10 patients will be presented. Also, it ends up creating this network of colleagues so that, I may be up in the northeast part of Arizona. I get to know colleagues all over the state of Arizona and New Mexico who are doing similar work to what I'm trying to do. Just so happens where I am, I have great colleagues. None of them are particularly interested in hepatitis C or HIV. So I would not have anybody really to talk to about those diseases. This gives me a whole community of folks that I can talk to. They're also, and have been from the beginning, they have a database of information they've been collecting about the treatment of these patients, so they can then look at their outcomes and see whether this is working well and improve it as necessary. So in terms of this whole, as I said, it started with hepatitis C. Hepatitis C is a pretty huge global health issue. There are over 170 million people infected. In the United States alone, there are 3 to 4 million people infected. And now I'm actually going to put on my ex-CDC hat a little bit and make a plug. I know that Deborah put in your folders at the back an editorial from the Annals of Internal Medicine that I really recommend you read. It's 2 pages long, and it's about the recent expansion of recommended screening for hepatitis C by the U.S. Preventative Services Task Force. That recommendation came out about a month and a half ago, and the recommendation is that every person in the U.S. born between 1945 and 65, so people 48 to 63 or 73, get screened for hepatitis C, because about 80% of the people infected with hep C in the United States fall within that age bracket. The CDC came out with that recommendation a year ago, and the U.S. Preventative Services gave it a grade B recommendation a month and a half ago. That is fantastic, because it means that Medicaid and Medicare should be ponying up to reimburse for those tests, or make it easier to argue for them doing that. So anyway, and actually yesterday, one of the reasons I'm here is Sanjeev knew I was going to be in Washington yesterday at a meeting of all the federal agencies that are part of Health and Human Services, including the CDC and the Indian Health Service, and the Bureau of Prisons was also there, as well as the VA and Medicare and Medicaid, to talk about developing or renewing a strategic plan for addressing viral hepatitis in the United States. In this issue of testing, in the baby boomer birth cohort recommendation was a key part of the discussion, and it's going to actually be coming down to all of you at the state level very soon, because how this gets rolled out, I know New York State in particular has been a champion in guaranteeing in the state of New York that that will be covered, the screening in New York. Hopefully other states will follow suit. So anyway, as I mentioned, there are about 30,000 people in New Mexico. About 1.5% of the population are infected with Hep C. In 2004, less than 5% had been treated. Also, about half of the prisoners in the state are infected with hepatitis C. That's probably not too far off from statistics in other states. My guess is 30 to 50% of the prisoners in many states are infected with Hep C. I know it's also true that most prisons test people for Hep C when they go into the prison. In general, they do not test them when they go out. The fact is, some people probably are getting Hep C in those prisons. They don't really want to know that, so they don't test for that. But it's a huge issue for the corrections departments. New Mexico has the highest rate of chronic liver disease and cirrhosis deaths in the nation. It was 25% higher than any other state. And in the state of New Mexico, Hep C was 10 times more prevalent than HIV. So a significant public health problem. So some of the good news about Hep C, and this is even back 10 years ago. At that time, with the medicines that were available then, 45 to 80% of cases were curable. So unlike HIV, which currently is not curable, it is suppressible, hepatitis C can actually be cured in most cases. And actually today, with some of the drugs that are going to be coming out in the next couple of months, and I know some of the folks sponsoring this meeting today are developing some of these drugs, the cure rates are going to be close to 90%. And the treatments are going to be very easy. They're going to be oral. Currently, the treatments involve an injection of interferon once a week, which has a lot of side effects. So that's the bad news side. Right now, the treatment that is available and has been for the last 10 years includes some drugs that cause a lot of anemia, cause neutropenia, or the white blood cell count going down, and also cause significant depression. The interferon part of that. And that interferon needs to be given by injection once a week. So logistically, it means the patient has to come in to the clinic once a week, and that can be difficult. And in New Mexico, there are a very limited number of specialists and no primary care doctors treating Hep C back in 2004. So just to go over a little more about our state, since there are no state representatives here in our audience. It's a pretty big state, 121,000 square miles, about 2 million people, pretty sparsely populated generally, diverse ethnic background, 47% Hispanic, 10% Native American, about 20% are below the poverty line, about 21% lack health insurance compared to 16% nationally. 32 of the 33 counties are listed as medically underserved, and 14 of the 33 counties are designated as health professional shortage areas. So as I said, the original goal really was focusing on developing local capacity in the state of New Mexico to safely and effectively treat Hep C in all areas of New Mexico and to monitor the outcomes of that treatment. That goal has shifted to become really have a national scope and a global scope. It's really now to create and disseminate a model for education and treatment that builds local capacity to safely and effectively treat complex diseases of a variety of kinds in both acute and chronic in rural and underserved locations nationally and globally. So this could be relevant for all of your states, potentially. So in terms of the methods for this training, it's using multipoint video conferencing, as well as using internet-based resources to leverage these scarce healthcare resources, both the scarce resources at the academic medical center and the scarce resources out in the local communities, and to link them up, create these knowledge networks, and Also, a disease management model that's focused on improving outcomes by reducing variation, increasing consistency in the processes of care, and sharing best practices, including using algorithms, checklists, and interdisciplinary chronic care teams. It's case-based learning, which is basically what people do in their residencies and fellowships, where there's, in your fellowship or your residency, you've got an attending physician who kind of oversees all the patients, but the residents and fellows are out doing most of the in-person work of collecting the data about the patient, formulating a plan, and then they usually sit down with their attending physician and they tell them the story and propose their plan, and they get feedback from that expert. And that's basically how this works. It's only happening virtually as opposed to in person. And then monitoring the outcomes, as I said, is an important part of this project. It's all HIPAA compliant. When cases are being discussed on this video network, names are not mentioned. You just say, I'm going to talk about a 43-year-old man who's Hispanic, and here's his problem. Who he is exactly is not relevant. So there were a bunch of partners initially, and that's relevant for this group. It was really the legislature of the state of New Mexico that backed this idea. Dr. Aurora went to the state legislature and said, look, the state has this significant public health problem. I've got an idea of how we might address it, and we need your support. And the legislature put up some money to pilot this program. And so the legislature was a key partner, and they remain a key partner. At this point, they're also getting funding from the Robert Wood Johnson Foundation. I think they got $8 or $10 million a year ago or so, and they're getting money from the CDC Viral Hepatitis Group and from the Center for Medicaid and Medicare, as well as the GE Foundation and others. The New Mexico Department of Corrections is a partner. The Indian Health Service is partnering with them. A number or a lot of federally qualified health centers are partners, and the Primary Care Association of New Mexico. So how's this different from telemedicine? Well, telemedicine, the idea of telemedicine is that one person at a hospital or academic medical center uses video conferencing technology, usually to link with one doctor and sometimes with a patient actually on the other end of the video. And the goal is to provide care and treatment for that individual patient. So this is a very different idea. It's really more telehealth, and it's more an educational capacity building idea where you're trying to build the capacity of those local doctors to treat lots of patients locally, not for the academic specialist to really, the academic specialist has no one-on-one relationship with that patient. It's the local doctors who remain the treating physicians and who have the relationship with the patient. So in this model, it's really, there's this multidisciplinary team, which is the hub at the university, and then scattered around the state, or this wide variety of providers at federally qualified health centers, in prison clinics, in Indian Health Service clinics, private practitioners. It's a wide variety of practice settings. Part of what they're trying to address is the fact that, as you all know very well, medical knowledge has exponentially increased over the last 30, 40 years, 50 years. And the individual doctor out in the community has a limited number of hours to do, to keep up with all the journals. It's very difficult to stay on the cutting edge of the literature for treating complex diseases. In things like viral hepatitis, Hep C, a huge amount of research and knowledge has been developing over the last 10 years, and for the non-specialists to keep up with that can be very challenging. Through a program like this, the specialists are basically able to boil down the key points and share those with their colleagues out in the community. There are a lot of benefits for these clinicians, and some of this is reiterating some points I've already made. For me, one of the things I've most enjoyed is actually interacting with my colleagues, not just the academic specialists at the university, but actually getting to know some of my IHS colleagues who are 2 or 3 or 4 hours away, who I don't get to see regularly or wouldn't see normally, and private practitioners and other doctors working throughout my region. So for me, it's been great to get to know them, and often I've picked up the phone and called them or emailed them outside of these, very 1-hour sessions that may go on once a week or every couple of weeks, depending on how often I'm able to participate. So that's really helped my professional satisfaction of having access to the experts and also this group of colleagues. I feel less isolated out in that very isolated place. I know that I can connect with, in developing this collaboration on Hep C for the Indian Health Service, I have colleagues in Alaska, Montana, South Dakota, Oregon, Oklahoma, who once a month we all get together on this video system and connect and talk together about our patients. It's been great. So also it's this very practical, it's a mix of, I will present a patient who I need an answer about how to treat them. So I probably tune into these things once or twice a week, once a week for the Hep C 1-hour session, once a week for these HIV sessions. They're usually at noon, so I do them during my lunch hour. Sometimes I'm presenting a patient, sometimes I'm just listening. Most of the time I'm listening to hear about other patients. Where I am, I'm treating 6 HIV patients right now. That's actually a very small number of people. For me to really stay competent as a clinician in treating HIV, I need to hear about a lot more patients than the 6 I'm treating. By tuning in once a week or once a month to hear about my colleagues treating their complicated HIV cases, it allows me to stay much more up to date in better, more ready to treat some of the complications that may come my way. On a very practical level, we're offered CME for no cost, so for every hour I put in participating in these, I get an hour of CME credit. And right now, the federal government budget is, basically our travel budget is 0. So for me to travel to do continuing medical education, I used to get something like $1,000 a year to support me to go and do continuing medical education, which obviously is, I need to do that to keep my license, and I need to do that to continue to be a good doctor. And right now, there's really very little support for that in the current fiscal environment. This is offering me one way to get lots of CME credit, and I'm not traveling anywhere. So it's actually pretty great. Also, they offer a way of getting certified as kind of a specialist in Hep C care, and if you do certain things, you can get a certificate in treating Hep C. And the Rheumatology Initiative has developed a program with the American Rheumatology Association so that if you complete a certain number if you attend a certain number of these clinics virtually and do a certain amount of work and take a little exam, you'll get a certificate in rheumatology, which is pretty great. And as I said, at the university, it's not just Dr. Aurora, it's Dr. Aurora with a psychiatrist who's a specialist in treating hepatitis C patients. There's a pharmacologist on the team that's an expert in treating Hep C and all the drug interactions. So we have access to this multidisciplinary team. I try, whenever I'm able to include on my end of the video, public health nurses and pharmacists who work with me, as well as social workers. So it's also helped promote a multidisciplinary approach on my end. This is kind of what it looks like. That's Dr. Aurora's back. So if the The lead faculty person is basically looking at these TV monitors, and you can see right there, there are about 8 different clinics that have tuned in, so he can see all of them. These are the various subject matter experts at the university. Also, they always do a 10 or 15-minute didactic presentation as part of the 1-hour clinic. This is what it looks like on my end. So when I'm up in Red Mesa looking at the video screen, I see, there's Dr. Aurora, there are the different experts in Albuquerque, and here are my colleagues from all over the state of New Mexico. So just to go over some of the evidence that was put together to show that this method and this model was effective, they did a large study, prospective study, and the objectives of that were to train primary care clinicians in rural areas and prisons to deliver hepatitis C care and treatment to local populations. They wanted to demonstrate that care and treatment provided under this model was equally safe and effective as that delivered at an academic medical center like UNM. And they wanted to demonstrate that this model improved access to hepatitis C care for minority populations. The end point of the study was, the bottom line was, how many people got cured of hepatitis C? And were the number of people, was the percentage of people getting cured out in the community equal to or better than the people that were going to the academic medical center? The definition of cure for viral hepatitis is a sustained viral response for 6 months or more after completing treatment. So they did this study from 2004 to 2008. They had 16 clinic-based sites. They had 5 prison sites. And then the control was the university clinic. The community cases, basically the subjects included were patients in the community going to these primary care doctors, and then consecutive patients in the hepatitis clinic at the university. This is a map of the state of New Mexico that shows where a lot of these sites were. I'm going to come back to this map later. It's a little more complicated than this actually shows where all the different clinics now are happening in New Mexico, but it gives an idea of the breadth of how they're spread out. So here are the outcomes. What they found was, and there were 261 patients enrolled in the group that were in the community, and about 146 that were treated at the university. And here's the SVR cure rate. So there are different rates for, there are a number of different genotypes for Hep C, and some are type 1 is harder to treat than type 2 and 3. But in any case, what they found was in the community, 50% of the patients were cured compared to 46% of the patients who went to the university. It's not statistically significant, but they actually were curing more patients than at the university. So it was equal to or better than the cures happening at the university. For genotypes 2 and 3, they were achieving 70% cure rates in the community and 71% at the university, equivalent. So this paper was published in 2011. That's when I read it in Vietnam. And it's actually a very accessible, fairly easy to read medical paper. And I recommend it to anyone who would be interested in reading more about the model and that study. I'm actually pretty close to the end. So in terms of the conclusions of that study, they found that rural primary care clinicians were able to deliver hepatitis C care and treatment under this model that was equally safe and effective as that provided in a university-based clinic. And it did improve access for minorities. Actually, I'll go back. I didn't point that out. So up here to show 68% of the patients in the community, almost 70% were minorities. Actually, only 50% were minorities who went to the university. So they really were treating a significantly larger number of minorities in the community than they were at the university. So they were achieving greater access for that population. Since then, over 500 of these weekly clinics have been conducted. Over 5,000 patients have been presented by doctors throughout the state. Over 6,000 CME credits have been given to doctors. They've done a lot of training on site as well, and they've gotten a lot of credit and appreciation for the model across the country. They had doctors fill out some self-evaluations of what they felt they were getting out of this program, and just the highlights of that show that basically the doctors in general felt their efficacy in being able to deal with hepatitis C and identify good patients that would be good candidates for treatment, their ability to assess the severity of liver disease in those patients and to treat them, that they doubled their sense of their own ability to do that. So there was a huge advance in self-efficacy among this group. They also felt like they were much better able to assess and manage the psychiatric comorbidities. They felt they could serve as a local consultant within their clinic or within their local area. And they felt that they were much better able to educate and motivate their Hep C patients as well. So overall, they felt like their sense of competence went from 2.8 on a scale of 7 to 5.5. Pretty major advance. They felt their professional isolation was significantly diminished. Their professional satisfaction increased to 4.8 out of 5. They enjoyed the collaboration. They felt that it really was expanding access to treatment for patients, almost 4.9 out of 5. And just all around felt that access to care was significantly improved. So we're coming down to the last, I think, 5 slides. So that was the Hep C model where this started. It's now, as I said, there are clinics for HIV, chronic pain, rheumatology, and complex multiple diseases. I think what works best for this type of model are complex diseases where the evidence is changing fairly rapidly and lots of new information is coming in, where treatments are rapidly evolving. Also, diseases where the social, societal impact both on health and economics are significant, and where the serious outcomes of untreated disease like death or serious morbidity are part of the program. And where standardizing evidence-based treatments really can significantly improve the outcomes. This is just a slide sort of re-emphasizing what I've already said about the network development between the university and community and private practice. And this just shows all the different locations in New Mexico where this is going on. For the different colors are the multiple different programs. In re-emphasizing the teamwork aspect, that chronic disease management is a team sport, and doctors need to work with nurses and pharmacists and community health workers, et cetera. I've actually already gone over most of these benefits to the health system. I think the demonopolizing of specialty care knowledge from the university out into the local communities is key. I think this issue of reducing variation in care is really important and leads to an improved quality and safety. And I think I've gone over most of these, so I think we can keep going. This is just a list of some of the universities and other partners that have replicated the model: University of Washington, University of Chicago, Nevada, Utah, Harvard, South Florida. The Department of Defense has actually become very interested in the model for treating chronic pain. and they've trained a lot of their chronic pain specialists at Walter Reed and down in San Antonio, and they basically assign teams to each of the commands. So AFRICOM has one team where there's an academic, or there's a medical center in the US that basically provides specialty consultation to AFRICOM or PACOM or whatever. And also the VA is using this quite a lot. A number of countries are starting programs, and I've actually been involved in working with a number of universities in Vietnam that are very interested in this, and the National TB program there. So in conclusion, using multipoint video conferencing along with best practice protocols and co-management of patients with case-based learning, essentially this model, it's a very robust method to safely and effectively treat common and complex diseases in rural and underserved areas and to monitor their outcomes. So this is the team of people that make this happen. This is actually Dr. Aurora giving a TED Talk 2 weeks ago in Albuquerque. So that'll probably be available online for anyone that wants to watch the 6-minute version of this by him. And here's his information. I would encourage you to check out the website. There's a nice 6-minute video of him talking about this as well. So thanks very much, and I'm happy to try and answer any questions.